Good morning, everyone. Dear chairmen, dear colleagues. It is a great honor to share with you the results of our hardcore validation study, which was validation of a novel non-invasive system for remote monitoring of left ventricular filling pressures in heart failure patients. As we know, management of heart failure patients based on left ventricular filling pressure monitoring leads to improved quality of life, reduced heart failure hospitalization, and in the case of HFrEF, also to reduce mortality. However, current devices used for this purpose are invasive, linked with periprocedural complications. They require long-term antithrombotic therapy, and they are costly. For example, insertion of CardioMEMS together with the device costs $20,000. Telemedical system Seerlinq is a C-certified MDR Class 2B medical device for non-invasive home-based monitoring of LVFP. It uses an algorithm, we call it hardcore, that analyzes photoplethysmography based on AI and hemodynamic principles. The patients require only a simple pulse oximeter that is connected via Bluetooth with their smartphones. They record their PPG 2 minutes in standing position and 2 minutes in recumbent position. The signal is then transferred to a secured cloud where it is analyzed by the hardcore algorithm in order to get an output which is a continuous variable. We call it diastolic reserve index, DRI, which is then transformed to LVFP, which are together with other vital parameters displayed on physician's dashboard. And the aim of this study was to validate the ability of the Seerlinq system to assess LVFP in heart failure patients. In order to do this, we designed a multi-center, prospective, observational, outcome-blinded study where we included adult heart failure patients that were divided into 3 cohorts. The first cohort, the right heart catheterization cohort, included patients scheduled for elective right heart catheterization, where LVFP was assessed as a pulmonary capillary wedge pressure. The second cohort, the echocardiography cohort, included patients scheduled for elective echocardiography, where the LVFP was assessed via diastolic dysfunction grade according to the 2016 ESC guidelines. And the last cohort, the third cohort, included the remote patient monitoring cohort, included patients in a pilot remote monitoring program, which were indicated for furosemide uptitration. The primary outcome for the first cohort was the discrimination performance of the diastolic reserve index, DRI, for elevated LVFP, which was defined as pulmonary capillary wedge pressure equal or above 15 millimeters of mercury. The secondary outcome was the correlation between DRI and pulmonary capillary wedge pressure. In the echo cohort, the primary outcome was the discrimination performance of the DRI for elevated LVFP, defined as diastolic dysfunction grade 2 or 3. And in the last, the remote patient monitoring cohort, the primary outcome was the change in DRI following furosemide uptitration. 134 patients were enrolled into this study and divided into the 3 cohorts. The baseline characteristics reflected typical heart failure population with a good balance of sexes. The average age was 69. Half of the patients had preserved ejection fraction, and majority of the patients were in NYHA class 2 or 3. I would like to point out that 22% of the patients were in atrial fibrillation, and we also included patients with severe valvular disease. And here are the results. In the right heart catheterization cohort, 21 patients were enrolled. And the diastolic reserve index showed excellent discrimination for elevated LVFP with a ROC AUC of 0.97. The secondary outcome, the correlation between DRI and pulmonary capillary wedge pressure, again showed a strong inverse correlation with a Spearman coefficient of minus 0.72. In the ECHO cohort, 112 patients were enrolled, and again, DRI showed good discrimination for elevated LVFP with a ROC AUC of 0.86. In the last remote patient monitoring cohort, 9 patients were included, and we recorded 15 furosemide uptitration events. The average increase of furosemide was 30 milligrams. And we showed a significant increase in DRI, which reflects the decrease in the left ventricular filling pressure 2 days post-treatment. And as we can see, in all patients, the DRI went up, which reflects decrease in LVFP. So to conclude the results of this validation study, telemedical system Seerlinq, which utilizes AI-based PPG analysis, demonstrated robust discrimination capabilities for elevated LVFP in heart failure patients, strong correlation with pulmonary capillary wedge pressure, and finally effective tracking of LVFP reductions following furosemide uptitrations. Telemedical system Seerlinq is the world's first CE-certified MDR Class IIb medical device for non-invasive, home-based monitoring of left ventricular filling pressure. And it has a potential to become a cost-effective remote monitoring tool to improve heart failure management. Thank you for your attention.
Thank you, Dr. Böhm. And we have a question.
So thank you, congratulations on this nice and impressive data. I mean, it was a one-time measurement, right?
Yes, it's one-time measurement.
For a few seconds.
2 minutes in upright position and 2 minutes in recumbent position.
And then the data will be transmitted to the mobile phone and AE-like program, and will analyze depending on the ECG waves or...
Yes, so the data, the photoplethysmography data, are transferred via Bluetooth to the mobile phone, and from the mobile phone to the cloud, and the analysis runs on the cloud.
Well, my intuition tells me that, unless I'm entirely wrong, to compare this with the CardioMEMS in everyday clinical practice, which already, you started the slide with CardioMEMS trials. Have you done it?
So as you're saying, this system is comparable to the CardioMEMS. However, it's much more cost-effective because it just requires a simple pulse oximeter and is non-invasive. But actually, we would love to compare it.
No, I'm asking head-to-head in the same patient.
Yeah, head-to-head comparison. So we are now working on finding partners for these comparisons.
Let's say it's implemented into clinical practice. What is the cost effectiveness? I mean, CardioMEMS always have the problem that it requires a lot of time for going back to the patients. Is that better, cheaper, or is it comparable?
Well, it's actually much cheaper because, as I mentioned, for example, insertion of CardioMEMS together with the device costs $20,000 compared to Seerlinq telemedical system, which requires just a simple pulse oximeter, which is like $50. And then, of course, it runs on the cloud, but these are very small costs. So it is much cheaper and therefore much more cost effective. And actually, we are already using it in clinical practice. So we are monitoring now more than 300 patients. And the results are very nice, but I can't tell more details because it will be presented in ESC in Madrid.
Okay, thank you very much. Very nice talk.